Today we are going to discuss a case of vaginal discharge. We take steps for history taking and clinical examination. After introducing yourself and shaking the hand of the patient to make a good relationship, you will start to take the history of the patient. The name of the patient, the age, how old is the patient, the nationality of the patient, and the social status of the patient. She is a virgin or married or divorced or widow. If she is married, how many pregnancy and outcome before, and if she is using a method of contraception or not. And also we will ask about the blood group and the RH typing. And then what's her job and the address of the patient and special habits, smoking, alcohol addicts, and or narcotics. Smoking, we will ask her when she starts to smoke and how many cigarettes she's smoking and for how many years she's smoking. The main problem of the patient is vaginal discharge. We will take the menstrual history, when she started her menarche, and what is the date of menstrual date, and so the patient is not pregnant, or she is pregnant first trimester or second trimester or third trimester or postpartum or post-abortive. When she did notice the vaginal discharge after the end of the period or before the period or after sexual relationship or after use of medication, and what is the amount and the quality of the discharge, not related to the period, or becomes more offensive during period, or increase after period, or decrease after period, or increase before the period time. What is the color of the discharge? Colorless, white, yellow, green, brownish blood. And you notice change in the color of the discharge, no change, becomes yellow, becomes green, or become bloody. What is the consistency of the discharge? The discharge is watery, or fluid, or mucus, or mucopurulent, or milky curds, or blood, or tissue, or urine, or feces. Clear. What is the amount of the discharge? It is minimal, or excessive, or droplet, or trickling. And what is the smell of the discharge? No smell, like smell of the blood of period, offensive, very offensive, urine or fecal smell. The patient is complaining of itching or no pain, itching, burning, soreness, discomfort, pain, stitching pain, tingling, numbness, thrombtic pain. Urine passes easy, or there is dysuria, or burning and dysuria, or burning pain and dysuria and urgency. The patient notices no soreness, or soreness and increase before the period and after sex, or soreness and burning and itching and vulvar swing all the time. Patient notice no visible lesions in the vulva, or there's vulval swelling, or vulval blisters, or vulval walls, or vulval ulcers, or vulval swelling. The vaginal soreness, or burning, or vaginismus, walls, or mass inside the vagina, or reducible swelling of anterior vaginal wall, or reducible swelling of posterior vaginal wall, or reducible vagina, or reducible descent of the cervix, or the uterus comes out of the vagina. This patient is continent all the time of guard urine, or she has stress urine incontinence, urine escapes during cough or straining, or to urinary incontinence, urine escape day and night and no desire to pass urine, or paradoxical incontinence, urine escapes day and night and also has desire, or nocturnal enuresis, urine escapes during night. The patient has abdominal pain or not, no pain, or heaviness, or dragging, or dull aching pain, or dull aching pain on one of the iliac fossa, dull aching pain on both iliac fossa. The patient has backache or no backache, lower backache, backache direct to the lower limb. The patient has generalized abdominal pain or not. The generalized abdominal pain is associated with no nausea or vomiting, or associated with nausea and vomiting or excessive vomiting. No special habits as regards personal hygiene, douching after sex, or excessive vaginal douching with water, or excessive vaginal douching with chemical materials. The underclothes is cotton or nylon fabric underclothes, or nylon fabric underclothes and tight pantalon or white pantalon. If the patient is not pregnant, what is the method of contraception she is using? Not using contraception, or using combined hormonal contraception, or progesterone only contraception, or intrauterine device, or condom, or safe period, or coitus interruptus, or vaginal diaphragm. In case of pregnancy, no bleeding or no gush of fluid, or there is bleeding or there is gush of fluid or trickling of fluid. In case of patient after delivery or abortion, pregnant in first trimester, pregnant third trimester, or delivery since week. Case of patient has malignancy, she has genital malignancy, radiotherapy for cervical cancer, radical surgery due to cervical cancer, radical surgery due to uterine malignancy, radical surgery for ovarian malignancy, radical surgery and chemotherapy for uterine or ovarian malignancy. The patient, she has previous vaginal discharge of similar conditions. This is the first time, or yes once, or yes several times. And what is the diagnosis of this? No previous problem, Candida albicans, or Trichomonas vaginalis, or chlamydia infections, or gonorrhea, or bacterial vaginosis, or pelvic inflammatory disease. She has received treatment for this or not, no previous treatment or local treatment, antibiotic, ketoconazole or fluconazole or flagyl tablet or zithromycin or doxycycline or penicillin or ampicillin, flagyl or clindamycin, ampicillin and flagyl. And the patient want to know the discharge before or not, no or yes, or what is the medication she is received. She don't receive any drugs, using oral hypoglycemic, or using insulin, and hypoglycemic, or using corticosteroid, or using immunosuppressive drugs, or using chemotherapy for treatment of rheumatoid disease, or using chemotherapy for treatment of malignancy. The patient notices change of the discharge and the smell after sexual intercourse or not. No change, or discharge become offensive and becomes increasing and more offensive. The patient has any pain or discomfort during sexual intercourse, no pain during sex, or superficial dyspareunia or dyspareunia or vaginismus inability to practice. If the husband has no urinary problems, or has burning and dysuria, or no milk carries after sex on penis, or soreness and feeling on the glands of the penis after sex. We will ask about the history of previous pregnancy, if the patient has previous pregnancy, when she has this pregnancy, and the duration of the pregnancy for how many weeks, and any problem occurring during pregnancy, was hypertension, hyperemesis gravidarum, diabetes, bleeding in early pregnancy, or premature rupture of membrane, or preterm labor, or anemia, or heart disease, or deep venous thrombosis, or HIV, or hepatitis. And the pregnancy ends in abortions, or towards ectopic pregnancy, or delivery. If the method of delivery, in case of delivery, is vaginal delivery, or forceps delivery, or cesarean section, and then newborn outcome, the sex of the delivery, male or female, and the weight, and any postpartum complications. hemorrhage or infections or neonatal complications, neonatal death or neonatal admission to oxygen inhalation, neonatal admission to artificial ventilation, neonatal sepsis, neonatal jaundice treated by exchange blood transfusion, neonatal anomaly, Erb's palsy, or neonatal injury, and the patient breastfeeding or not breastfeeding. We make summary for the history and we go to examine the patient. Usually we look for the general examination of the patient, and the patient is not pregnant. We look there's no abnormality detected in the abdomen, or the tenderness on one of the iliac fossa, or the tenderness on both iliac fossa, or tender swelling on one iliac fossa, or bilateral tender swelling on both iliac fossa. If the patient is pregnant, the uterus is felt abdominally and uterus soft and felt abdominally, or localized tenderness over the pregnant uterus, or diffuse tender pregnant uterus, or generalized abdominal tenderness. If the patient in postpartum period, abdomen lax and uterus soft, or tender postpartum uterus, or tender postpartum uterus and tenderness of one iliac fossa, tender postpartum uterus and tender post-iliac fossa, tender postpartum uterus and tender swelling of one iliac fossa, tender postpartum uterus and tender swelling of post-iliac fossa, or generalized abdominal tenderness. Then we look for the vaginal examination. We inspect for the discharge, no discharge, or white milky curds, or scanty, very offensive vaginal discharge, or yellow fussy vaginal discharge, or brown discharge, or blood discharge, or purulent discharge, or mucus discharge, or mucopurulent discharge, or watery discharge, or urine, or feces, or tissues. We ask the patient to see the patient's cough and escape of urine, or there is continuous dribbling of urine due to urinary incontinence. The skin of the vulva is no apparent lesions or scratching marks, or there is redness, or there is blisters, or there is vesicles, or there is warts, or there is ulcer, or the vulva is swollen, or the skin of the vulva is atrophic, or leukoplakia, white patches of the vulval skin, or hypertrophic thickened skin, or phosphatic incrustation due to continuous dribbling of urine in case of urinary incontinence. We look for the Parsonin glands, not palpable, or the Parsonin cysts, or there's Parsonin abscess, the Parsonin is swollen and tender and painful, and discharge comes out of it. No pus, or the pus comes out of the Parsonin swelling, or pus comes out of the orifice of the urethra, or pus comes out from the vagina. We look for the enteritis. When the patient is strained, there is descent of the anterior vaginal wall, eucystocele, or descent of posterior vaginal wall, rectocele, or descent of anterior and posterior vaginal wall, cystorectocele, or descent of the cervix, first-degree uterine prolapse, or the uterus is outside, second-degree uterine prolapse, or the whole uterus outside, second-degree uterine prolapse, or uterine prolapse with the cubitus ulcer or vaginal wall. We look for the vagina. There is no discharge, or the white milk curds, or yellow fussy discharge, or greenish discharge, or mucus, or mucopurulent discharge, or watery discharge, or there is urine coming out, or feces, or tissues. We do speculum examination. Normal vaginal skin, or there is redness, or strawberry vaginal wall, or vaginal swelling, or those warts, lesions, or opening of urinary fistula, or opening of fecal fistula. The cervical discharge is mucus, or watery, or mucopurulent, or bloody, or frank blood. We look for any lesion of the cervix looks normal, or the cervical erosion, or cervical ectropion, or Naposian follicles, or cervical cyst, or cervical polyp, or uterine polyp, or cervical ulcer, or cervical mass. Then we do Do digital examination of cervix. Cervix is firm, cervical polyp, or uterine prolapse, polyp or bilateral cervical tear, or cervical ulcer, or cauliflower cervical mass, or cervical cancer extending to the vagina, or cervical warts, or cervical nodules, or tenderness or moving the cervix. Douglas pouch, we are looking for the Douglas pouch. This is normal, or there's boogie mass in the Douglas pouch, and then they will look for the size of the uterus. In case of patient not pregnant, normal antiverted, antiflexed uterus, or normal size retroverted, retroflexed uterus, or small antiverted, antiflexed uterus, or bulky uterus, or enlarged soft tender uterus, or enlarged uterus, or symmetrical enlarged uterus. Case of the patient is pregnant, the uterus is soft and normal, or the tender pregnant uterus. In case of postpartum, the uterus is normal, involuted, or tender postpartum uterus. And then we look for the adnexa. In case of non-pregnant patients, the adnexa is not palpable, or tender on one adnexa, or bilateral tender adnexa, or tender swelling of one adnexa, or bilateral tender swelling of both adnexa, or ovarian cyst, or ovarian swelling. Case of the patient was pregnant, normal uterus, or tender one adnexa, or bilateral tender adnexa, or tender swelling of one adnexa, or bilateral tender swelling of both adnexa, or ovarian cyst, or ovarian swelling. In case of postpartum cases, the normal adnexa is not palpable, or tender on one adnexa, or bilateral tender adnexa, or tender swelling of one adnexa, or bilateral tender swelling of both adnexa, or ovarian cyst, or ovarian swelling. So at the end of the examination, and we can reach the cause of vaginal discharge is due to the pregnancy problem or infection, or most probably in case of infection it is lower genital tract infections, or it is due to pelvic inflammatory disease. In rare conditions, discharge is due to problem of malignancy, or fecal or urinary fistula, or urinary problems.